So, good afternoon. Welcome to the last PET session of the year. It is a whole afternoon stroke evening of PET. I'm going to make it as exciting as I can. There'll be lots of breaks. There's going to be some work from you, a little bit of teamwork as we go into the case studies. So you'll be working with some random groups. And then we try and make sure that we don't finish too late so that you're able to do what you need to do. So welcome to the session, the last session. And this is really about what we call SPOT, which is about the specificity, progression, overload, and timeout. And this is about planning our exercises. So we've got what happens in the early stage, what happens in the mid stage, and then what happens at late stage. So this is really what we're doing with our exercises. So what do we want you to learn by the end of today? We want you to really be using those SMART goals to do some rehabilitation planning. Okay, thanks, Laura. Much appreciated for that. That's great. We've got to apply the laws of specificity. We've got to make sure that we're providing enough overload. We've got to make sure that we're doing either a progression or a regression. We've got to think about rest and recovery. And then we've got to implement these principles as well. Okay, now I've gone to town with the principles. You know them inside out, back to front, upside down, because they are so important, because you're going to need those for the rest of your career. The CSP has obviously just changed everything to the 4 pillars. And one of the first pillars is exercise prescription. So just bringing you into focus for the last time this year, what is our profession about? Okay, it's about human anatomy and physiology. Okay, movement and function, maximizing wellness, minimizing disease and injury, and solving those real world problems, of which we have many at the moment. So we're focusing on the physical side of things. You remember that the sport is really about the physical components of fitness, and then the Billy side is more about behavioral change, more about the psychological side of exercise. So we've got different ways of understanding what's going on, but we're going to focus on specificity, progression, overload, and timeout. Traditionally, physios haven't done very well at this in the past. Talking to my friend Claire Minchell, has anybody listened to the podcast with me and Claire? Thumbs up in the chat if you have. Give me a quick thumbs up in the chat if you've listened to the podcast with Claire and I. Stunned silence. Has nobody listened to the podcast? Has nobody listened to any of the podcasts? Give me a thumbs up if you listen to just one of the podcasts. Anybody hearing me? As part of the directed study, okay, as part of the directed study, there's a load of podcasts for you to listen to right at the beginning of the PET module. Okay, you need to make sure you listen to those podcasts because it's a nice form of passive learning. Okay, so Candice has listened to a few. Give me a thumbs up in the chat if you've listened to the podcast, just by way of a check. Yeah, most of you have. Okay, just checking there. I was a little bit nervous there that you haven't been doing the director's study. I'm sure you have, and the podcasts that are part of that director's study. Okay, so we've still got to think about exercise even when the patient is fully rehabilitated, because they've got to do maintenance exercise, because everyone should be exercising regardless of their ability. Everyone should be doing something. It's very important. We're born to move. We're not just born to sit still and do nothing. Okay, so exercise is still the end goal, and what we can do is we can sort of plan backwards. It's called backward performance thinking. Anybody listen to the podcast with myself and Dr. Lee Harrington? Thumbs up in the chat if you've listened to that one yet. It's next semester, but You might have listened to that one. Anybody listen to that? No. Okay. Well, obviously the podcast's not as exciting as I thought they should be. So Lee talks about backwards performance thinking. So we've got our functional task here, and then we work backwards from it effectively, so that we still do the task, but we're just working backwards from it. So we've got our early stage stuff, okay, and this is the things that we generally won't see in the NHS. This is the very acute side of things, and then we'll see the subacute, and then we'll see the chronic. So chronic is anything longer than 3 months, because that's the healing time for most things, apart from probably sort of bone. And then we've got subacute, which is 6 weeks to 3 months. And then anything sort of less than 6 weeks is acute. Thumbs up in the chat if you're happy with those terms, early, mid, and late, or acute, subacute, and chronic. Make sure we're happy with those guys. Quick thumbs up in the chat. Let me know you're there. Fantastic. So everyone happy with those terms. So it's really making sure that we're exercising appropriately for whatever stage that we should be at. And that's where we as exercise prescribers come in. So we've got to think of this experience as the patient journey. And that's actually part of clinical governance. So clinical governance is kind of overarching or underpinning in everything that we do. Patient journey is massively important, and we've got to start with thinking, where do I need to get to? Where is my end goal? Okay, because that's my long-term goal, and then we break that down into bite-sized chunks, and they're called short-term goals. They must always be smart, okay? That's specific, measurable, achievable, realistic, and timed. Okay, I know you know all this, and we've got to think about where we are in this journey. Okay, and what we can do is we can get something called acute on chronic. That's when someone has an acute flare-up of something that's already established, and this happens in things like tendinopathy. Okay, so just be aware of things like acute on chronic, which is interesting. So we've got this clinical reasoning, and we go on and on about clinical reasoning. Okay, clinical reasoning is thinking about our thinking. What does that mean? Well, we are the only, as far as we know, we are the only creatures on the planet, okay, that can think about their thinking. So by thinking about your thinking, you can have a thought, and then you can have a thought about your thought. So what we're doing is we're thinking about the needs analysis, which is the task and the individual. We're watching the patient do the task, and that will be part of movement analysis. We're linking it to what they're struggling with, and then we form a hypothesis about why they're struggling, what exercises would help, and then did the exercise help? Remember that a training effect might need to occur before we can get our result. So we've done all this sort of stuff to death. This is just sort of reiteration. So we've also got to think about the healing times for what's going on. Obviously, we've got different structures, things like we've got the soft tissue, then we've got things like bone, then we've got tissue grafts, like an anterior cruciate ligament, for example. We might be dealing with more complicated trauma that might need an exofix or something like that. But these phases of treatment will differ depending on the age of your patient. Obviously, younger people recovering quicker than older people just due to the speed of their metabolism. So we've got to know where they are with regard to their healing time on this continuum in order to prescribe the right exercise at the right time. So it's really important that we think about, okay, this is where we need to get to. Let me just highlight that. So this is where we need to get to. We want good posture, good biomechanics, exercising regularly. How do we get there? Okay, we've got to make sure that we're not interrupting the regeneration of the tissue, and we've also got to make sure that we're not causing more inflammation. So just type in the chat, guys, is exercise pro-inflammatory or anti-inflammatory? Type pro or anti. Is exercise pro-inflammatory or anti-inflammatory? Yeah, it's all pro-inflammatory. Okay, so exercise is going to increase inflammation, and sometimes that's not a bad thing, particularly with regard to acute on chronic. So we're going to introduce you to the exercise physiologist. This was my first degree, exercise physiology, and we've got to think about long-term. Okay, so long-term problems. We have got a huge amount of patients, an increasing amount of patients with long-term health problems. So we've got to manage those long-term health problems. We want to stop them in the first place by doing the prevent and provoke, but sometimes through no fault of your own, the patient develops these symptoms. So they're going to work with the exercise physiologist for things like weight loss, metabolic conditions, and also the chronic conditions, things like diabetes mellitus, high blood pressure, cancer in particular, some types of mental health, heart disease, and arthritis. So all of these groups need exercise, but they need it prescribed just right, because if we get it wrong, we can flare these patients up significantly. We've got to make sure that we're doing strength and conditioning, and that we're giving them a manageable training load. So there's someone else in the NHS that does what we do, the exercise physiologist, and normally we work in hand, combined with them. And we tend to sort of do more the hands-on management, and the exercise physiologist tends to do more the planning of rehabilitation. So that's important that we understand that. If we don't understand other roles in the MDT, we won't know where we fit within the MDT. Just type in the chat yes or no. Anybody worked with an exercise physiologist before? Yes or no, guys? Yeah, so Neil has. Okay. So just Neil. Neil, in what capacity have you worked with an exercise physiologist? Can you just let me know? In what capacity have you worked with an exercise physiologist? Don't be shy. Type it in the chat. So it's to do with, okay, cardiac. Yeah, okay, cardiac rehabilitation. Sorry, cardiac and pulmonary rehabilitation together. Yeah, thanks for that, Neil. So these are things that we'll be doing. We do cardiac rehab next semester. So obviously look forward to that. So we're thinking about, imagine we have these 3 pillars. So you've got these 3 pillars that basically everything exercise prescription wise we need to get right. Specificity, okay? We must train specifically for what we need. Yeah, if you want to sit to stand, you must practice sit to stand. You can't just do knee extensions sitting in your chair. Okay, that is the wrong motor program. Okay, then we've also got to make sure that we're progressing it. Okay, lots of physios with their patients, they're very scared to progress. Okay, because or they're cautious with progression, too cautious. Normally, what happens is physios are under training people. There's 1 or 2 physios that do overtrain people. And then we've got to think about the overload and the various ways that we overload our patients. So this is key to what we're doing, because if we get this wrong, okay, we could either injure our patient or just be suboptimal in our training. Okay, so Claire Minchell has very kindly let me have this analogy, if you like, and we've got a really important slide coming up now that again Claire's let me have, and this was only last year when we were presenting at Therapy Expo together, and this is the hierarchy of importance during rehabilitation. So it's really important because we're going to need different components of fitness at different times within the rehab. Okay, so just by way of involvement, okay, what are the 3 components of fitness that we need early on? What are the 3 components of fitness we need early on? Type it in the chat, guys. It's where you interact with me. What are the 3 components? So just give me one component. What are the 3 Okay, strength and flexibility. Strength, flexibility, yeah. So we need strength and flexibility. And there's one more. It is balance, Neil. Okay, it is balance. Okay, so we need to restore range. Let me just check what slide is next. Yeah, okay. So this is the components of fitness hierarchy. Now, this is not exclusive. It's just to give you a bit of a template about how these things work. So the number one thing we need is flexibility. We need to restore that range of movement. If we haven't restored that range of movement, the joint is going to struggle to function. Then we need to restore balance. Okay, that is the motor control, so the proprioception and also the stability. Okay, center of mass over base of support. And then we start with strength, isolated, okay, maybe isometrically, that will then become endurance. And then strength that becomes endurance as we integrate it, okay, to either functional movement or we use load. So those two are synonymous. Then we're going to add some functional movements with maybe a bit more speed to create an intensity. And then eventually we'll start layering components of fitness. And the last ones we're finished with are power. Okay, just give me a thumbs up in the chat if you're happy with that hierarchy of components of fitness. Yeah. Fantastic. So that's important that we understand that. So if we go back to this slide here, so we can see that we need strength really early on. Okay, so we do what we call the strength foundation. And then later in late stage rehab, we don't need strength so much because we're now focusing on power. Okay, so for instance, we might, if we're rehabilitating the knee, for example, we might spend a lot of time doing strength. Okay, so level 1 functional movements and open and closed chain. Okay, and then later on, we're going to develop power. So we might do some jumping, some plyometrics. So we don't need so much strength later on in the rehab because we've already got that foundation of strength. Same thing here. We're going to spend a lot of time with balance and proprioception early on. Okay, and then towards the end, we should already have this because we've already got the foundations of strength, of balance, and of range of movement. Okay, and then what we call the performance sensory motor abilities. These are balance, these are accuracy, things like coordination and agility. So these come on much, much later. So we've got late stage components of fitness and early stage components of fitness. Okay, so give me 3 components of fitness that are late stage. Type it in the chat for me. Late stage components of fitness. Type it in the chat there, guys. Late stage components of fitness. Okay, yeah, power, accuracy, speed, agility. Yeah, power, power. It's all about the power, the rate of force development. Good. So we now understand this hierarchy of fitness, and we can apply that to lots and lots of our patients. So a lot of time we spend going back to the basics. So when we go back to basics, we're talking about restoring range of movement, we're talking about strength, and we're talking about balance and proprioception. That's what we mean when we go back to basics, because that foundation needs to be strong. Otherwise, you can't build upon it. You're building a house on sand, as the saying goes. We've also got to think about the 4 Ps of functional movement. The meaningfulness of the task is so, so important. And I drive this home, okay? In order to get our patients to do what they need to do, it must be meaningful to them. So it must be task-orientated. So patients come in and say, my knee hurts when? Okay, when I go up the stairs. Okay, my shoulder hurts when, I don't know, I put something on the top shelf, or I'm putting on my jumper or something like that. there will be pain associated with a dysfunctional task. Okay, so everything is always related to the purpose. Ask yourself the question, for what purpose am I doing this exercise? So that you'll see a lot of stuff posted on social media that is pointless exercise that looks good. Okay, it looks good, it looks like it's flashy and it's eye-catching, and it is exactly that, but its purpose is meaningless. Yeah, it doesn't do what it needs to do. It doesn't address components of fitness. What it does is it just looks a bit flash. Okay, it's people showing off. And we've got to be careful that we don't get drawn into this kind of media-inspired, make the exercise complicated without understanding the purpose of the exercise. So, for instance, you might see people doing squats on a Bosu ball. So, while that looks impressive because they're working strength and balance at the same time, they're not really working optimal balance and they're not really working optimal strength. And unless there's a task where you've got to perform squats, I don't know, on a boat or something like that, or on a trampoline or something like that, it's completely non-functional, isn't it? It's completely non-functional. So it's just showing off for no reason. Then we've got to think about the position. What position do we want our patients to be in? Are they going to be standing, sitting, kneeling, on their back, on their front, on their side? Okay, so the position is massively important. So we must always think about changing position, making sure that we can work all those muscle groups, all those functional movements from different positions. The postural alignment, elbows in, elbows out. Okay, where does the hip, knee, ankle need to be? Where does the spine need to be? And then obviously the pattern of movement. And that's normally a level 1 pattern of movement. Okay, so you've got your all your level 1 functional movements there. Give me a few level 1 functional movements, guys. Type them in the chat for me. Level 1 functional movements. Type a few of them in there for me, please. So we've got squat, lunge, push, pull, gait. Yeah. Push, pull, gait. Yeah. So we've got twist, hip hinge. Yeah, well done, Amy. Okay. So we've got those 7 level 1 functional movements, and they're normally the foundational patterns that we've got. So moving on, we've got to think about the specificity of the task. Okay, so for example, here we've got someone doing a split jerk. Okay, that's the little cartoon character up there. So if we look down at the bottom, on the front leg, his right leg, okay, we know that he needs enough weight-bearing dorsiflexion. So he needs to be able to get the knees over the toes in order to do that task. He needs to have enough length in the contralateral hip flexor on the left. He needs to have stability of that left ankle in order to do this particular task. Okay, it's going to be a level 3 functional movement because what he's doing is he's pushing up fast at the same time as doing a lunge type movement. So he's doing 2 movements at once that requires coordination, and he's using load, which means it's a level 3 functional movement. He's got to be able to lock his arm, his arm out. Okay, so he must be able to extend the elbow, and he must be able to support load above his head, which means that he needs full shoulder movement flexion into elevation. So you're beginning to start analyzing the task. Okay, so what level of functional movement is this? This is a level 3 functional movement. Okay, and it's the combination of a lunge pattern and a push pattern together with load coordinated at the same time, which is why it's a level 3 functional movement. So what does he need in order to do that? Well, he's going to need all his components of fitness, but we're focusing on power because this is more of a power movement because it's done at speed with load. Okay, so the limitations of this exercise might be shoulder flexibility, might be thoracic spine flexibility, okay, might be a rotator cuff injury. So we've got to think about all the specifics of the particular task, which is why you do movement analysis. And then we've got to think about the individual. What is the impairment? Okay, what components of fitness need addressing? What's their age? Because that's always important. What's their previous exercise experience? Are they an Olympic athlete, or are they brand new to doing any sort of physical activity? What is the purpose of what we're doing? Okay, breaking down those patterns into the push pattern and the lunge pattern, for example, with that, and breaking down the task into those manageable chunks. If we don't do that, then we're doing our patient a disservice. And then we've also got to think about outcome measures. Outcome measures is not a session we do till next semester, but we still got to think about that. So for instance, in our range of movement flexibility session, you did something like knee to wall. Okay, that would be a good outcome measure for flexibility. Single leg calf raises or single leg step downs. These are a good way of testing muscular endurance. The Y balance test, a great way for testing balance and proprioception. Grip dynamometry. Okay, so I've got a grip dynamometer here. Okay, how much can I grip? Okay, and that measures strength. And then we've got things like functional reach test, which is a balance test for our elderly population. Okay, we're basically forming a fist, leaning forwards, okay, until you overbalance. We do those next semester. Just popping back, just thumbs up in the chat, guys, if you're happy with the term outcome measures and you're beginning to understand the importance. Fabulous. Okay. Really important that I take you along the journey with me. So we're going to come on to overload. So the overload principle, the drive principle. Now, I got it wrong the other day, and I can only apologize. So the R of drive is not repetitions, it's rest. Okay, so that's my bad. That's my fault. Okay, I taught you wrongly using my own acronym. Okay, I will punish myself with burpees later on. I understand that that was a very bad thing to do. However, I'm now teaching you correctly. So the drive principle, the duration, the rest, the intensity, the volume, and the energy system are very much dependent on how we prescribe that exercise. Okay, normally the overload, okay, is associated with resistance, because we're thinking about strength or power. Okay, because they're the things that we need to do. That's strength training is so important. And we can mess about with the strength training that we do. So we can make it more strength endurance. Okay, we can make it more sort of power related, or we can also make it pure strength, one repetition max stuff. So in order to overload, we're basically going to make the patient lift heavier or use a heavier resistance band. We can increase, okay, the speed or the intensity, so that they're doing more in the same amount of time. Okay, we can increase the distance, i.e. working on their muscular endurance or their cardiorespiratory endurance. The volume consists of the sets and the repetitions. That's the total load for that particular session. And then we come on to the acute and the chronic workloads in a second, and then decreased rest time. Okay, so you can do an exercise that's really easy, like sit to stand with your patients, and then rather than give them a minute or 30 seconds to recover, you could just give them 10 seconds to recover and make them do that a couple of times. By decreasing your rest time, you'll create overload and get a training effect. I use that lots with my patients. Who's heard of Tabata, Professor Tabata's work from Japan? Just say thumbs up in the chat if you've heard it. Originally done with cycling, and what we've done is we've generalized these principles across, okay, and they seem to work, but cycling was the original one that we've done. So we've got our sets, reps, and load. Okay, we've done this last week or the beginning of this week. So when we're working strength, guys, how much rest time should we get in between sets when we're working strength? How many minutes? Type it in the chat. 2 to 5, cartons all over it. Yeah, so the longer, the heavier you're going, the longer the rest time. Now, if we're working muscular endurance, how long should we be resting between sets? How long? Okay, probably 30 seconds. Yeah, about 30 seconds is a nice round figure. And if we're working muscular hypertrophy, 3 sets of 10, what's the normal recovery? Not that we encourage this, obviously. Yeah, exactly that, Mark. Anything between 30 seconds and 90 seconds for muscular hypertrophy. Well done there. Okay, so we've gone on and on about this, okay, but physios everywhere I go, okay, because 10 is a nice round number, okay. So originally, after the Second World War, they do 10 sets of 10. You might know that as German volume training, but 10 sets of 10 was the standard. So doing 100 repetitions in order to create muscular hypertrophy, because that was the only way of effectively seeing that our patient has improved. Now we've got lots of clever testing, so we can think about things like strength and power training, which is less repetitions and heavier, and then we've got muscular endurance training, which is far more repetitions but a much lighter weight. Now, there is a time to do 3 sets of 10, okay? But when you're learning, we must appreciate the fact that if we want strength, we've got to make sure we're lifting heavy enough, okay? And if we want endurance, we must make sure we're light enough. And we must try and push the patient towards muscular failure in order to create the overload. If we don't do that, then we're not going to get the results that we want. Remember that muscular hypertrophy, okay, is significant only to hypertrophy. You won't get the same strength gains, you won't get the same endurance gains. So if you look at athletes, athletes are completely tailored for what they need to do. Right, how do you work out the 1 repetition max for strength? This is where it gets a little bit complicated. Okay, so what happens is we can't test a 1 repetition max on most of our patients. They simply won't do it. The NHS doesn't have is not equipped with weights heavy enough to do that. But we can do an equation in order to get that. So say, for example, we're talking about a bench press. So we're lying on our back in the supine position and we're just pressing, okay, a bar above our chest, which is a push functional movement. And we might be able to manage 60 kilograms for 10 repetitions. Yeah. So what we're going to do is that we're going to multiply those 10 repetitions. So we've fatigued, we failed to lift any more than 10 repetitions at 60 kilos. So we times 10, because that's the number of reps that we did, by 2.5, that gives us 25. And then we minus 100 from that, which gives us 75. And then that gives us a percentage. Okay. And then what we do is we estimate this 1 repetition max, okay, against the theoretical 1 repetition max. And that gives us our theoretical 1 repetition max. Okay. So what this is doing is saying that if we can bench press 60 kilos for 10 repetitions, we could probably only do 80 kilograms, okay, for 1 repetition. That would be our strength training. Okay, does that make sense to most people? You could use any number you want, but that just gives you an example of how to work out 1 repetition max without ever having to actually do strength training to find that. Just give me a thumbs up in the chat. I know it's maths and it's a little bit complicated. Give me a thumbs up if you're happy, guys. Yeah, fantastic. Okay, so it's just working out 1 repetition max without the complexity, sorry, not the complexity, without the risk of injury, because when you're going for a 1 repetition max, lots can go wrong. So we do what we call isolate to integrate. So we might start with a limb that's injured, for example, and we just use the way to get, say we're repairing muscles around the knee. We might start off with some simple knee extensions in sitting. Yeah, open chain exercise. Okay, just lifting the limb up against gravity. Then we might combine that into either a lunge or a squat movement. Then we might start adding some resistance bands, because they're a nice way of loading up with tension. Then we might start adding load or weights, and then we might incorporate functional movement. So we've got this continuum that we're using. So we might start with that isolated quads contraction, because we've got pain inhibition of the muscles around the knee. Then we might do an unloaded knee extension. Then we might do a loaded knee extension. We could use TheraBand, for example, okay, or an ankle weight. And then we could integrate into that functional movement. Okay, so we could progress or regress depending on what we need to do and what we find. And patients are always fluctuating up and down this scale, okay, because obviously pain inhibition switches off muscles, and we must be mindful of that. So we've got our 6-step exercise progression model. Again, there's lots of other ways to do this. Okay, it's the way Claire works, it's the way I work. So we're going to do some isolation and some education. We isolate and educate, then we're going to add some resistance, then we add functional movements or functional positions, then we're going to increase function with resistance, then we're going to work multiple muscle groups as we integrate, okay, that particular movement into more complicated movements, and then we're going to add and layer components of fitness. Okay, thumbs up in the chat if you're happy with our 6-step exercise progression model. Yeah, great stuff. Okay, so that is the way we're always going to work. If you understand that, then you can prescribe exercise for anyone, because you know how to progress or regress accordingly. So I'll just let you read that. Okay, so this is what we see in our training all the time. So somebody might come in with maybe like Achilles tendinopathy or something like that, and they can only do 5 single leg calf raises on the symptomatic side, okay, before they fatigue. So if they keep practicing that, okay, because it's 5 repetitions before they fatigue, they're lacking strength, aren't they? Okay, and then if they practice that for a little while, they gain the strength, and then they're able to go from strength into endurance. So they fatigued at 5 to begin. A couple of weeks later, they can now do 20 repetitions. And what happens is, because we haven't increased the load or the challenge or the difficulty, we're no longer strength training, we're endurance training. Okay, and that's very different. So we're now not working specifically the strength that we wanted, we're working endurance, which is okay, but it's just not optimal. Okay, so when we exercise, we're physiologically creating muscle damage. Yeah, we are tearing muscle fibers in order for them to heal in a better way. And this is what we call super compensation. So the more intense the exercise, the longer that we need to recover. That's why it's important to say, if you've just run a marathon, you know, give yourself a week off. Okay, allow the body to recover before you start going on and training at that level again. Okay, so here, if you can see the pointer, we've got our bout of exercise here, and then we're going to damage the muscle, and then the body heals, okay, which is the super compensation, okay, and then we're ready to go again. And then this keeps going up and up and up if we get it right. Okay, if we get it wrong, okay, i.e. we do a big bout of exercise, it's going to take us much longer to recover. Yeah. And if we do a short period of exercise, we're going to recover too easily. So we're constantly monitoring this. So you could effectively under recover as well as overtrain. Okay, overtrain, you're doing too much. Okay, with regard to the duration, the intensity, the volume, and the energy system. And then undertraining is really about the rest. You are not resting and you're not recovering enough. Give me a thumbs up in the chat if you're happy with the difference between overtraining and under recovery. Overtraining and under recovery. Yeah, good. That's important that we understand that. So we can still, if somebody has a bad night's sleep, okay, they're going to take longer to recover from that bout of exercise. So we've got to be mindful of what's going on there. Okay, here's where things get a little bit complicated. So what we want to do is we want to work out how much training our patient has been doing over a week, okay, and compare that to how much they do over the month. And this is called the acute to chronic workload ratio. Yeah, and the way we work out a workload ratio is your rate of perceived exertion. So between 0, which is no effort, and 10 is maximal effort, and how long you did that particular activity for. So for instance, if you were doing a tough CrossFit workout that's only 3 minutes, okay, you might only be exercising for 3 minutes, but you were exercising for 10 out of 10. So 3 minutes times 10 gives you 30 of these arbitrary units. Okay, now you could do that in 3 minutes, or you could do a very low intensity exercise that's only 3 out of 10 for 10 minutes, and they give you the same workload effectively. Now, this is not a science. This is based on rate of perceived exertion, so it's very subjective, but how long they did that particular amount of work for. So if we're using the example that we've got here, so if we did a rate of perceived exertion 6 out of 10, and we did that for 100 minutes, okay, that gives us an arbitrary unit of 600 arbitrary units. Yeah, does that make sense? So 6 out of 10 was the rate of perceived exertion, did that for 100 minutes, gives you an arbitrary unit score of 600. Yeah? Now, if we were to train 3 times a week at that same level, it now gives us an arbitrary unit of 1800. Okay, and that now is our weekly or acute workload. Okay, you got to stay with me on this one. Thumbs up in the chat, guys, if you're happy with the acute workload. If you're training 3 times a week, for example. Yeah, not too complicated so far. Ben and Liam are with me. Right, now we're going to work out our chronic workload. So our chronic workload means our monthly workload, okay? So which consists of 4 weeks or 28 days. So depending on how much time the individual had or how much workout they were doing, okay, it can vary between 1,200 arbitrary units and 1,800 arbitrary units, which was the week that we just did. So we can see that we've got a fluctuation in our weeks there. Yeah? And what we want to do is we want to add all these weeks up and then divide them by 4 so we get an average chronic workload. Yeah? So this was last week. This was week 3, 1,800. Okay? There it is there, 1,800. But that was our hardest week that we trained. So if we add up those 4 weeks, divide it by 4, okay, and it gives us 1,500 or 1,500 as our arbitrary unit. And that's our chronic workload, our monthly workload. Thumbs up in the chat if you're happy with that, guys. Thumbs up in the chat if you're happy with how to work out a monthly workload. Good. Okay, now where potentially it gets a little bit confusing, because we're now going to compare the acute to the chronic. Yeah, no, don't worry if I've lost you. Okay, it's all you're doing is comparing. Okay, so let me go back again. So we've got our rate of perceived exertion, which is a scale between 0 and 10, and then the time that we're doing this particular exercise. Okay, so in this example, we've got 6 out of 10 is our rate of perceived exertion, and we did that for 100 minutes. So it gives us a score of 600 for that day of exercise. Now, if we did that same training routine 3 times a week, 600 times 3 is 1800, and that gives us our weekly workload. Okay, then if we look at our monthly workload, we can see all the different scores that we've got. Okay, so we were a bit lazy in week 2 and we made up for it in week 3. Okay, we're going to add all those weeks up, divide it by 4 because there's 4 weeks in a month, and that gives us our chronic workload. And then what we're doing is we're comparing our chronic workload to our acute workload. Okay, so for example, this might be our acute workload, 1,400, and our chronic workload is 1,500. So if it's between 0.8 and 1.3 as a ratio, then that's our safe zone. So we've got to remember our safe zone is between 0.8 and 1.3, okay? Which means that we're not increasing our training too much too quickly. Because if we increase our training too much too quickly, that's when we start to get injured. Okay, and then we keep progressing until we hit that plateau and we get the law of diminishing returns. Okay, so if we go back to this one, so we're using week 1 as the example now. Week 1 was 1,400 arbitrary units. So if we're looking at week 1, okay, week 1 compared to our chronic workload, 0.93, that's well within 0.8 to 1.3. So that is a safe training program. Yeah. If your training increases over 15%, your injuries are just going to go through the roof. Just give me a thumbs up in the chat if you're happy. Okay. All you've got to know is that safe zone, that acute chronic workload ratio is between 0.8 and 1.3. Just quick thumbs up in the chat if you're happy with that, guys. Okay, so some of you, okay, who's not happy with that? Just be honest. Okay, we're not going to single you out. Okay. Yes, that's for everyone. Yeah, so that's for everyone. So our safe zone is always between 0.8 and 1.3. Yeah, okay, and this comes from, it is an interesting way of managing progression. And this comes from Tim Hodgett's work, okay, on acute chronic workload ratio. Now, I don't want to go into it too much, but what we're doing is we're giving you an equation about how to manage progressive overload. So what we're doing is we're giving you an evidence-based way of managing overload over a period of time. Does that make sense? Yeah. So this is a great way of measuring all that stuff that we've got to do, because a lot of the time we will be asking our patient to keep an exercise diary, and we're asking these two things. We're asking for rate of perceived exertion and time that they did that activity. Yeah, that gives us our workload for that workout, and then how many times they did that per week. Then we compare that to how many times they do that per month, and that gives us a ratio. As long as that ratio is between 0.8 and 1.3, we're not overtraining, so it's happy days. Okay. So I'm going to give you an example of where you've got physio, hands-on intervention, and then exercise, which here we've got called rehab. So We might start in the early stages. We might do some hydrotherapy. We might do some manual therapy, some massage, compression. Then we're going to work balance. Then we're going to work strength and a little bit more balance. We'd also be doing range of movement here. Then as we get on to the subacute phases, okay, we've got all this active range of movement exercises, strengthening, okay, massage, manual therapy. But now we're doing strength training. We might also do some midline stabilization and some balance and proprioception. But now we're also thinking about maintaining cardiovascular fitness. And then as we move on, we're doing position-specific fitness training. So the specific tasks that that person needs to do. Okay, so this is an example from rugby. Okay, so we're going to maintain range of movement. So even though we're strength training, we don't want to lose range of movement. We're doing balance and proprioception. And now we're getting into full contact training, which is power. Okay, so we maintain strength and cardiovascular fitness, because they're the two things that we tend to lose quickly. We tend to lose cardiovascular fitness or cardiorespiratory fitness, and we tend to lose strength. So they're the two things that we always want our patients to keep and maintain. Whew, that is a pretty heavy going session, isn't it? That's why we leave that till right at the end. So if you look at what we've done, we've covered the principles of specificity. It was, Emma, yes, it was. We've covered the principles of specificity, progression and regression, overload, timeout. We've given you some equations about how to work out 1 repetition max and how to work out acute chronic workload ratios. Okay, so it's a really nice way of managing the workload that we do. So what I would like you to do now is test your knowledge. And the only way to test your knowledge is with a Kahoot quiz. So let me just fire up the Kahoot quiz. And there's only 5 questions in this one. That's enough. So I'll give you the code in a second. As soon as it comes up. The code is 6523173. Okay, 6523173. Okay, I'll just type that in the chat. 6523173. Okay, hopefully you can jump in. Let me see if I can share my screen. Hopefully you can see that. Yes. Okay, we've got a few of you in already. So there's 28 in the room, but there's only 20 on Kahoot, guys. 21. Who's not on Kahoot yet? Come on. It's the last one, guys. Make sure you play. Come on. We've got 22 in the room. I need another, at least another 3. Good. Another 2. Oh, somebody's dropped out. What's going on, eh? What's going on? Couple more of you in the room. That's better. There you go. Loads of people are in now. Oh, we just had a couple drop out. What's going on? Dodgy internet connections. So hopefully we're just going to grab a few people back in the room. Okay, and we shall begin. Right, exercise rehab planning. Let's go. Okay, question 1. Which one of the following best represents the acronym SPOT? Fantastic. 21 of you getting those right. But let's see who was fastest. It was Helen, then Micah, then Bethan, then Neil, then Lou. Question number 2. Which one of the following best represents the calculation for 1 repetition max? Oh, okay. So that was a trick question because, okay, I used the example of 60 kilos. Okay, so what you need to do is to go back to that 1 repetition max equation and have a look at that because there's a little bit of a misunderstanding there. 5 of you getting that right though. Okay, who's at the top? Neil rises to the top, then Helen, then Mike, then Bethan, then Lou. Which one of the following best represents the exercise progression model? Yes, isolate, add resistance, then function, and resistance. The majority of you getting that right. Well done. Micah, you're on top, then Bethan, then Isaac, then Neil, then Ben. Okay, all to play for. Question 4. Which one of the following represents the safe zone for acute chronic workload ratio? Fantastic. Most of you getting those right. Okay, 0.8 to 1.3 is our safe zone for acute chronic workload ratio. Mike's still at the top. Isaac creeping up, then Bethan, then Neil, then Ben. Last question, all to play for. Which one of the following is not a definition of acute chronic workload ratio? Okay, it's not the average of 4 weekly workouts. That's a kind of a trick question there. Okay, I was a little bit naughty. So let's see who's in third. It's Lou. And who's in second? It's Mike R. But our winner is... It's Helen. Well done, Helen. And our runners up, Isaac and Bethan. Very well done to all of you guys. Absolutely fantastic. Well done. Well done, guys. Good job. Very good job. Let me come back into the room. Yes, well done indeed. Okay, so I don't know about you, but I need a break. Okay, so it is 1 minute past 3. So let me stop the recording here.